of acute rheumatic fever. I feel proud that National Heart Foundation Cardiac Course, arranged by National Heart Foundation Hospital, selected me as a moderator of this session. আমি এই মুহূর্তে বাংলায় কিছু কথা বলতে চাচ্ছি। আমি আনন্দের সাথে জানাচ্ছি যে আজকের আয়োজনে আমরা করোনা বিজয়ী দুইজন যোদ্ধাকে ফিরে পেয়েছি, যারা জীবন মৃত্যুর মাঝখান থেকে ফিরে এসেছেন। তাদের একজন হলেন অধ্যাপক ডাক্তার মীর জামাল উদ্দিন, আর একজন ডাক্তার এম এ মজিদ খান। তাদেরকে আমরা আমাদের এই আয়োজনের পক্ষ থেকে অভিনন্দন জানাচ্ছি। আর যে সমস্ত চিকিৎসকগণ করোনায় মৃত্যুবরণ করেছেন এবং তাদের আত্মার মাগফিরাত আমরা কামনা করছি। আর যারা এখনো জীবন যুদ্ধে লড়ছেন তাদের জন্য আমাদের সুস্থতার জন্য আমরা প্রার্থনা করে যাচ্ছি। আমরা আরো এই মুহূর্তে মনে করতেছি আমাদের এই একজন মেন্টর, আমাদের এই একজন প্রিয় প্রফেসর অধ্যাপক ডাক্তার আবুল হোসেন খান চৌধুরী, যিনি এখন মৃত্যু শয্যায় কাছাকাছি। তার জন্য আমরা সবাই দোয়া করি। আমরা আমাদের অনুষ্ঠানে আবার ফেরত যাচ্ছি। আজকের অনুষ্ঠানকে আমরা ভাগ করেছি 3 ভাগে। একটা এক্সপার্ট ওপিনিয়ন, এক্সপার্ট মানে প্যানেল থাকবেন। আমাদের 4 জন লেকচারার আছেন, তারা বক্তব্য দিবেন। প্রত্যেক লেকচারের পরে কিছু সময় দেওয়া হবে তাদের প্রশ্নের উত্তরগুলো দেওয়ার জন্য, এবং সর্বশেষে ওপিনিয়ন ফ্রম দ্য এক্সপার্ট। আর সবাই শেষে আমরা বোর্ড অফ থ্যাঙ্কস দিয়ে চলে যাব। সর্বপ্রথম যেটা আমরা বলতে চাচ্ছি, আজকের এই আয়োজনের প্রধান এক্সপার্ট প্যানেলিস্ট, examiner's perspective is Professor Mir Jamaluddin Ahmed. Jamaluddin, Director NICBD, and he is the Director General, he is the General Secretary, Bangladesh Society of Cardiac Interventions. He is a renowned intervention cardiologist and his special interest in radial procedure. Next expert in next expert are from our institute, Professor Fazilatunisa Mali. She is the head of the department and director of Academic Council of National Heart Foundation Hospital. She is well known to all. He is nationally, internationally reputed intervention cardiologist. Next, Professor Abdul Audu Chaudhary, head of Department of Cardiology, Dhaka Medical College and Hospital. He is an intervention cardiologist and most popular man. And in our hospital, from Professor M. Badiujaman, he is also intervention cardiologist of our hospital. Another professor from National Heart Foundation is Professor Tuhin Haq of echocardiography. Our associate professor panelists are Dr. Mir Nesaruddin Ahmed, Dr. Ashok Kumar Datta, Dr. Habibur Rahman, Dr. Tawfiq Shahriyar Haq, Dr. Kabiruzzaman of echocardiography. Welcome all these experts in these sessions. Next, our presenters are Dr. Najmul Laila. She is the registrar of National Heart Foundation Hospital. She will tell us about the etiology and pathogenesis of acute rheumatic fever. And next, Dhiman Boni, associate professor and senior consultant of National Heart Foundation. He will deliver clinical presentation and diagnosis of rheumatic fever. And next, Dr. M.A. Majid Khan, assistant professor and consultant, National Heart Foundation Hospital, have an echocardiography of acute rheumatic fever. And last of all, Dr. Khalid Mohsen, associate professor and senior consultant. He is also intervention cardiologist and he is popular among the doctors and families. এবং প্রত্যেকটা প্রেজেন্টেশনের শেষ হওয়ার পরে কিছু সময় তাদেরকে দেয়া হবে কিছু প্রশ্নের জন্য, এবং সেই প্রশ্নের উত্তরগুলা দিয়ে আমাদের অনুষ্ঠানটা একটু মানে তাড়াতাড়ি সংক্ষিপ্ত করতে হবে, কারণ 2 ঘন্টা 2.5 ঘন্টা পার হয়ে যাচ্ছে। সমস্ত লেকচার শেষ হওয়ার পরে এক্সপার্ট ওপিনিয়ন আসবে। এক্সপার্ট ওপিনিয়নের পরেই আমরা মানে এন্ড অফ দি সেশন করে উইথ থ্যাঙ্কস দিয়ে চলে আসব। তবে এই মুহূর্তে আমরা প্রথমেই আমাদের যে প্রেজেন্টার আসবেন তাকে আমি অনুরোধ করব। তিনি হলেন ডাক্তার নাজমুল লাইলা, রেজিস্ট্রার, ন্যাশনাল হার্ট ফাউন্ডেশন হসপিটাল। She will deliver the etiology and pathogenesis of acute rheumatic fever. Dr. Nazmul Laila, please.
I'm Dr. Nazmul Laila. I'll be presenting the etiology and pathogenesis of acute rheumatic fever. Acute rheumatic fever is a multi-system autoimmune response to untreated or partially treated group A streptococcal pharyngitis. A single severe episode or recurrent episodes of acute rheumatic fever can result in permanent valve damage and lead to rheumatic heart disease. The incidence of acute rheumatic fever began to decline towards the end of the 19th century, and by the 20th, it was almost unheard of in the affluent population. But the major burden of acute rheumatic fever and rheumatic heart disease is confined to the developing countries of sub-Saharan Africa, South Asia, and the Pacific region, indicating their inadequate access to healthcare, poor functioning healthcare system, and social inequality. The global burden of disease study puts rheumatic heart disease burden at 33 million prevalent cases, causing 275,000 deaths and more than 9 million disabilities. This is the burden of acute rheumatic fever, and it is seen in 4 patterns. The first is seen in red or maroon. It is pattern A, and it's the pre-antibiotic fall, and it reflects the incidence of acute rheumatic fever in the developed countries like the US and the UK. The second pattern, seen labeled B or seen as green, shows the persistently high incidence of acute rheumatic fever in developing countries and amongst the indigenous population of developed countries like Australia and New Zealand. The third pattern in blue, shows the post-antibiotic fall, and it was typical of certain developing countries like Tunisia and Cuba, where there's a fall in the incidence of rheumatic fever following implementation of public health programs for primary and secondary prevention of rheumatic fever. The third pattern in D or purple shows a fall followed by a rise, sharp rise in the incidences of rheumatic fever. This occurred in the former Soviet Union, areas like Kyrgyzstan, and it reflects the weakening primary healthcare system and rising economic crisis in the region. So the peak incidence of acute rheumatic fever occurs in those between the ages of 5 to 15 years, with a decline thereafter, and cases are very rare in patients older than 35 years. Only 5% of first incidents have occurred, first attacks have occurred in children less than 5 years. And in children less than 2 years, it is almost unheard of. Acute rheumatic fever is equally common in males and females, but rheumatic heart disease seems to be more common in the females. The prevalence of rheumatic heart disease and rheumatic fever showed us a substantial and promising decline in Bangladesh from the 70s to the early 2005. This table shows the prevalence of rheumatic fever and heart disease amongst children between 5 to 19 years of age. And it clearly shows that the prevalence amongst the male and the female children was equal at 0.6. But there was a slightly more prevalence, markedly more prevalence amongst the rural population, where the prevalence was at 0.7 per thousand compared to 0.2 per thousand in the urban areas. The prevalence of rheumatic fever is at 0.6 per thousand, and that of rheumatic fever with rheumatic heart disease at 0.9 per thousand. So the risk factors of rheumatic fever and rheumatic heart disease is basically overcrowding, poverty, malnutrition, inadequate healthcare facilities, and inadequate access to these healthcare facilities, social stigma, and lack of compliance to secondary prophylaxis, and certain genetic factors. Outbreaks of acute rheumatic fever follow epidemics of streptococcal pharyngitis. An adequate treatment of streptococcal pharyngitis reduces the incidence of subsequent acute rheumatic fever. An appropriate antibiotic prophylaxis prevents recurrence after an initial attack. Studies in population where acute rheumatic fever is common find no definite association between the group A streptococcal sequence, previously thought as rheumatogenic sequence, and the non-rheumatogenic strains, and the site of infection, that is trophism for the skin or throat, or the ability to cause the disease. Group A streptococcus is divided into three groups based on their degree of hemolysis. There is the alpha hemolysis, beta, and the gamma hemolytic streptococcus. Beta hemolytic streptococcus is further divided into more than 20 Lanesville groups. It is the group A beta hemolytic streptococcus, Streptococcus pyogenes, that is responsible for acute rheumatic fever. The pathogenetic basis of acute rheumatic fever and carditis revolves around molecular mimicry and autoimmunity, whereas the pathogenesis of rheumatic heart disease is a complex interplay between multiple streptococcal antigens, various cross-reactive antibodies, and multi-pronged immune targets. This is a flow diagram showing the occurrence of the first episode of acute rheumatic fever. And there are various factors involved here. First, we have the environmental factors like overcrowding and poor hygiene and low nutrition, malnutrition, or these features. And then we have the genetically determined factors, which is found in certain, which is responsible for the familial clustering. And finally, we have the agent, that is the group A streptococcal, streptococcus carrying various virulent factors. All three act on a susceptible host and eventually lead to the first episode of rheumatic fever. So actually, rheumatic fever is a multifactorial disease that follows group A streptococcal pharyngitis in a susceptible individual who lives under deprived social conditions. The theory of molecular mimicry holds that group A streptococcal pharyngitis triggers an autoimmune response to epitopes in the organisms, and that cross-reacts with similar epitopes in the heart, brain, joint, and skin. And eventually, repeated episodes of an acute rheumatic fever leads to involvement of the heart valves, more commonly mitral and then aortic. And so eventually we have rheumatic heart disease. So the host factors are the genetic susceptibility factors. Several genes have been found in familial clustering. And what are these genes? These are genes that are involved in adaptive immune response, like the HLA class 2 alleles. Those involved in innate immune response, like mannose binding lectin-2. Cytokine genes, commonly, the most commonest are tumor necrotic factor alpha and transforming growth factor beta. And B-cell alloantigens, most commonly D8 by 17. D8 by 17 has been found in high titers in patients who eventually develop rheumatic heart disease following repeated attacks of acute rheumatic fever. Environmental factors have been discussed quite a few times. The commonest are low socioeconomic status, underemployment, overcrowding, poor nutrition, and reduced access to healthcare. The streptococcal M protein share an alpha helical coil structure with the cardiomyocyte contractile proteins, myosin and tropomyosin. In molecular mimicry, there is a recognition of the targeted intracellular biomarker antigens, that is the cardiac myosin and tropomyosin, and in the brain tubulin, while targeting extracellular membrane antigens like laminin or laminin basement membrane proteins on valve endothelium, or lysogangliosides and dopamine receptors on the brain. Some cross-reactive autoantibodies target the dominant group A streptococcus, that is epitope. It is an antigen. It is N-acetyl beta-D-glucosamine. These recognize cardiac myosin and tropomyosin and target laminin or valvular endothelium, leading to valvular damage. Autoantibodies that are not cross-reactive to streptococcal M protein, rather they are cross-reactive to collagen type 4, may form and lead to similar systemic inflammation and connective tissue damage. How these endothelial cells demonstrate structural and functional variability in response. Some cross-reactive antibodies mediate damage to the endocardium, myocardium, pericardium, leading to widespread endothelial activation in the form of fibrinous degeneration, damage to the collagen fibrils, and connective tissue ground substance. However, these usually resolve without any residual damage. Some antibody-mediated damage to the endothelial leads to expression on the cell surface of vascular adhesion protein 1. And these cause further infiltration of T cells and new angiogenesis, and a vicious cycle of damage, healing, and scarring ensues. So coming back to the flow diagram again, we have a first episode of acute rheumatic fever. And in patients who are inadequately treated or untreated, we have repeated episodes of acute rheumatic fever. Eventually, valvulitis leads to valvular damage, and we have what is called rheumatic heart disease. This is the other autoimmunity that ensues. Here, the streptococcal M protein. Here, the streptococcal M protein enters into the basement membrane, and via its octopeptide motif, it binds to collagen type 4 and renders this collagen immunogenic. Autoantibodies are actually directed against this collagen rather than the streptococcus M protein, leading to systemic inflammation, widespread damage, endothelialitis, and eventually with little residual damage except for the valves. The pathognomic features of rheumatic fever. Ashworth's bodies are the pathognomic feature of rheumatic fever. It consists of lymphocytes, occasionally plasma cells, plump activated macrophages and histiocytes called NHF cells, which are seen in blue. And there also occurs caterpillar cells, which are large activated macrophages with prominent nuclei and condense chromatin into long wavy ribbons. In arthritis, an inflammatory process ensues that causes damage to the collagen fibrils and connective tissue brown substance, and a little damage to the superficial portion of the subendothelium. This is called fibrinoid degeneration. In Sydenham's chorea, where this intracellular biomarker antigen in the brain is tubulin, and the actual target antigen on the cell surface are lysogangliosides and dopamine receptors. And this causes a calcium calmodulin dependent kinase 2 activation and dopamine release. And finally, we have the features of Sydenham's chorea. Thank you very much.
That is why acute rheumatic fever is rare in children below the age of 5.
So children usually start going to school by the age of 5 years. And also that is the reason why it is also more common after 5. Not that it doesn't occur below 5. 5% of first incidences have occurred below 5 years of age. And also autoimmunity is rarely occurs before the ages of 5. So that's why it is more common in children after 5 years of age.
Another question is, does Bangladesh call low risk zone?
So now from the recent statistics, it seems so, because our prevalence is at a rate of 0.9 per thousand. And in the revised Jones criteria, if it's less than 1 per thousand, it is now described to be in the low risk zone.
Can streptococcal skin infection causes acute rheumatic fever?
No. So before, it was previously thought that there was tropism for this. I have shared a slide already. Before we thought that there were rheumatogenic strains and non-rheumatogenic strains, and there was tropism for skin and throat. But now that previous thought no longer holds. There is no such evidence anymore.
Do you think that's accepted worldwide, or this a hypothesis of a school of thought?
Beg your pardon, sir, I didn't get your question.
Has the recent guidelines recognized that the nephrogenic strains can also cause acute rheumatic fever? Or is it a school of thought that has not been yet fully established? Which one?
Probably a school of thought, sir.
Yeah, so it's no longer hard, you cannot tell.
Yes, sir. Yes.
Probably not thought.
Can I add a few words actually? Regarding the nephrogenic strains are quite well defined, 4, 12, 49 and 57. Among them, the strain number 49 is very much notorious for causing glomerulonephritis. But regarding the rheumatogenic strain, there is no such identifiable strain. And another school of thought is that the cholesterol of the skin, it inhibits the streptolysin O. antigen, and it inhibits the genesis of the cardiac complications from the cholesterol of the skin has some role to play.
Yeah, that's the prevalent thought as yet. Can I ask you a question? How many of the rheumatic carditis patients ultimately develop rheumatic heart disease?
Sir,
How many of the rheumatic carditis patients ultimately develop rheumatic valvular heart disease?
so I think it's about more than 50%, if I'm not, I think it's 57%.
It's around, say, some studies suggest two-thirds to 70% or more. So it's imperative that we treat the sore throat early on if we suspect it's GS-induced, group A streptococcus.
I think another question, why rheumatic heart disease is more common in mitral valves? I think it is for Dr. Dhiman Bonik next time. So he will present the clinical presentation and diagnosis. I'll go for that. Next presenter is Dr. Dhiman Bonik, Associate Professor and Senior Consultant, and he is also intervention cardiologist in National Heart Foundation Hospital. He will present the clinical presentation and diagnosis of acute rheumatic fever. I like to.
Colleagues and friends, today my presentation is on clinical presentation and diagnosis of acute rheumatic fever. Acute rheumatic fever typically follows an episode of streptococcal pharyngitis after a latent period of 2 to 3 weeks. About 58% of the patients have no symptoms of pharyngitis or sore throat. Rheumatic fever occurs more frequently in children between the age of 4 to 15 years. In developing countries, lesser age group may be, it is documented that around 3 years rheumatic fever is present. Among the presentation, joint involvement is the most common, and it almost it is present in 100% of the patient. There are some typical criteria of arthritis in patients with acute rheumatic fever. It is known as migratory polyarthritis. Migratory polyarthritis means one large joint will involve. It involves mainly the knee, ankle, and the elbow joints. One inflammation subsides and the next one develops. After completion of one completely subsides and the next inflammation develops. It may be additive also. Joint pain may be additive in rather than migratory. The affected joint may be inflamed for weeks, days to 1 week before inflammation subsides. It may persist up to 2 to 3 weeks before it resolves completely. If the joint swelling of rheumatic fever persists after 4 weeks, it is necessary to consider about other differentials, commonly juvenile idiopathic arthritis. Monoarthritis may be presenting feature of rheumatic fever. It is around 17 to 25% of the patient. Large joints I have previously mentioned. Commonly, analysis of the synovial fluid of the joints are not done in case of rheumatic fever. If done, there is a presence of sterile inflammatory fluid. If radiology of the joints are done, there is joint effusion, but there is no abnormalities. Other abnormalities are not noted. There is a term which is known as Jukot arthritis or arthropathy, which is chronic post-rheumatic fever arthritis. It is a rare manifestations of rheumatic fever characterized deformity of the joint. This condition may occur after repeated attack of rheumatic fever and results from recurrent inflammation of the fibrous articuloid. There is no true erosion on radiology, and the rheumatoid factors are usually negative. This differentiates it from the rheumatoid arthritis change of joints. You can see the swan neck deformity of the Jukot arthropathy and the ulnar deviation. It is said that in 2015 Jones revised criteria, arthritis of rheumatic fever responds promptly to non-steroidal anti-inflammatory drug, and thus the classical presentation of migratory polyarthritis is infrequent. And it is said that if rheumatic fever arthritis persists more than 72 hours after adequate dose of non-steroidal anti-inflammatory drug and aspirin, then the other differential should be thought of. The other important differentials of the polyarthritis of rheumatic fever are, there is a autoimmune disease such as juvenile idiopathic arthritis, the reactive arthropathy, septal arthritis, and there is a term known as post-streptococcal reactive arthritis. Post-streptococcal reactive arthritis is a term which is commonly caused in close proximity of rheumatic arthritis, that it is diagnosed in patients where the arthritis is not typical of rheumatic fever, but who have the infection has a shorter latent period than the period of rheumatic fever. It is less than 1 week period, that is less than latent period of rheumatic fever, and it is less responsive to non-steroidal anti-inflammatory drug, and there is less manifestations to carditis, and these post-streptococcal reactive arthritis are more manifestation of renal disease. The distinction between post-streptococcal reactive arthritis and rheumatic fever is unclear, and many would recommend that a diagnosis of post-streptococcal reactive arthritis is not to be made in populations in whom rheumatic fever is more common. Even the diagnosis is considered, it is appropriate to offer a period of secondary prophylaxis, so for episodes of acute rheumatic fever in such high risk population. Now comes the carditis. Carditis is the most serious manifestation of rheumatic fever, and this gives rise to acute rheumatic fever, and this gives rise to chronic rheumatic fever, and ultimately atrial fibrillation, stroke, heart failure, infective endocarditis, and death occur. The incidence of carditis varies from 40 to 91%, and in the 3 to 6 years it is about 50%. There is a report of 1987 UTA outbreak in the United States that 91% of carditis when clinical examination was combined with echocardiography. The symptoms and signs of carditis depends on whether there is involvement of pericardium, myocardium, or the heart valve, that is endocarditis. If endocarditis is involved, the most common valvular lesion is mitral regurgitation, causing an apical pansystolic murmur. Aortic regurgitation is less common in acute rheumatic fever. Stenotic lesions are uncommon in the early stage of the disease. There is an transient apical mid-diastolic murmur, which is known as Caricom's murmur, may occur in association of the mitral regurgitation. In patients with history of previous rheumatic heart disease, a change in the character and intensity of the murmur or the appearance of a neo murmur will indicate the presence of acute rheumatic carditis. Now comes the myocarditis. Myocarditis in the absence of valvulitis is unlikely to be a rheumatic in origin. Valvulitis must be involved in presence of myocarditis in case of rheumatic fever. Patients with myocarditis may develop cardiomegaly and congestive heart failure, and which may in turn give rise to severe life-threatening complications. Mitral damage myocardial damage can manifest in ECG, showing different grades of atrioventricular block. If there is first degree AV block, it is asymptomatic. If the patient develops second or third degree AV block, then even pacemaker is needed if the patient has congestive heart failure. Congestive heart failure may be caused by a myocarditis or in severe involvement of one or more heart valve in case of acute heart failure, acute rheumatic fever. In acute rheumatic fever, if the patients develop heart failure, we should thought of the patient have myocarditis or there is severe involvement of one or more heart valves. Pericarditis is associated with anterior chest pain and pericardial friction rub may be detected on clinical examination. Pericarditis may be detected clinically in about 10% of patients. Pericardial effusion may be in various from mild, large pericardial effusion is sometimes developed. Pericardial tamponade and constrictive pericarditis usually does not develop. The echocardiography is said to be a more sensitive and specific marker rather than cardiac auscultation in detection of acute rheumatic carditis. In 2015 revised Dhaka-Jones criteria, it is recommended that all patients with suspected or definite rheumatic fever should undergo echocardiography. This is the very important slide of minimum echocardiographic criteria for the diagnosis of pathologic acute carditis. This is a feature of mitral regurgitation. These are the features of aortic regurgitation. If all the 4 points are present, we can say that there is aortic regurgitation. My next speaker, Modi sir, will be elaborate on this. Next comes the sydenum scoria. This is known as St. Vincent's dance. Chorea may be the only presentation of rheumatic fever. It occurs more commonly in females. It occurs in around 30% of patients with acute rheumatic fever. The latent period of chorea is much longer than the arthritis and carditis. It is about 6 to 8 weeks. Chorea is characterized by the presence of involuntary, purposeless, jerky movements of hands, arms, shoulder, feet, legs, and face and trunk, associated with hypotonia and weakness. The purposeless movements of chorea interfere with the voluntary activity and it disappears during sleep. This is the important feature of chorea. Chorea may be confined to face or one arm, and it is sometimes known as hemichorea. There are some important clinical signs of chorea. Patients shows more motor persistent by involuntary withdrawing of the tongue, and if the patient is attempting to protrude the tongue, it is known as jack in the box or the reptile tongue. Another important findings of chorea is an milkmaid sign or milking sign. If the patient is asked to hold the examiner's hand, this holding will be repetitive, irregular squeeze and squeezing and losing the hand. This is known as milking sign or milkmaid deformity. There are other deformity of other signs of chorea, dinner fork deformity or pronator sign, balismus. There is if the children has features of chorea, there will be a change in his handwriting, and if you give him to write a single sentence, first there will be macro size of the words, then gradually the micro size, and there will be emotional lability in the patient or the children. Importance are behavioral changes, restlessness, outburst of anger and crying, and learning deformity. This is a video clip of chorea of a child. I cannot cover his face, sorry. These are the features of chorea. You can see involuntary movements of the hand, face. This is a 1.5 minute video clip. This is the jerky speech. You see the I'll speak on more. Chorea may last for 1 week to 2 years, and it usually lasts for 8 to 15 years. This is the chorea. This is the jerky movements of the hands. When chorea occurs alone, the ESR, C-reactive protein, and the ASO titer may be normal. It is the examination of going to be the pronator sign. You see the and this is the pronator sign. These are the tongue fasciculation. This is the valismus. This is another involuntary movements of the hands, fingers of the hand. This is the spooning sign. This is the Dinner frog deformity sign. This next, the presentation of acute rheumatic fever is another presenting feature is subcutaneous nodule. It is less common. It is around less than 10% of in case of acute rheumatic fever. It occurs in the occiput, elbow, ankles, and knee joints, and Achilles tendon, as like the nodules of rheumatoid arthritis. Nodules are firm, painless, free, movable over the subcutaneous tissue, varying size of 0.5 to 2 centimeter. It mainly differs from rheumatoid nodule by that rheumatoid nodule is present on the extensor aspect of the upper forearm, and it is present on the joint, the rheumatic fever. And the nodule are smaller in size, more discrete, and less persistent than rheumatoid nodule. These are the two important differentiation for rheumatoid nodule. This is a picture of, this is the elbow joint, this is the rheumatoid nodule. Nodule are usually seen in children with prolonged active carditis rather than in early stage of rheumatic fever. Multiple coughs of nodule may be related to the severity of rheumatic carditis. Then another less common feature is erythema marginatum. It occurs in about 4 to 10% of patients with acute rheumatic fever. Erythema marginatum is less common manifestation of rheumatic fever, occurs in the arms or trunk, not on the face. The rash is evanescent, pink, and non-pruritic. It extends centrifugally while the skin at the centers returns to normal and has an irregular serpiginous border. The rash may also become more prominent after a hot shower. These are the erythema marginatum rash, and you can identify that the area in between the pen mark, this is already the rash is absent. You can show the caption here. Approximately 60 minutes before there was rash. After 60 minutes, it is absent, and there is centrifugal extension of the erythema marginatum rash. Other manifestations of rheumatic fever are fever common in almost all patients. The fever are from 101 degree Fahrenheit to 104 degree Fahrenheit. Fever usually decreases within 1 week and rarely lasts for 4 weeks. The other features are rapid sleeping pulse rate, tachycardia out of proportion of fever, malaise, and anemia may be noted in patients with acute rheumatic fever. Now, regarding the diagnosis, no specific clinical laboratory or other tests exist to confirm the diagnosis of rheumatic fever. The diagnosis is usually made by using the clinical criteria first formulated by T. Duckett Jones in 1944 and subsequently 1992 and 2002. In 2015, there is a revised of this Duckett-Jones criteria by American Heart Association, supported by WHO. There are some change in the 2015 Duckett-Jones criteria. This revision has allied itself with international guideline by defining high-risk population, recognizing the variability of disease burden and presentation, categorizing recommendation according to the favored classification, recommendation, level of evidence categories, and reflecting the era of echocardiography. This is a very important slide of reverse Duckett-Jones criteria for diagnosis of acute rheumatic fever. Number one, the primary episode of rheumatic fever is diagnosed by two major criteria or one major, two minor criteria, plus the recent evidence of preceding group A streptococcal infection. Recurrence of rheumatic fever is diagnosed by two major or one major and two minor criteria or three minor criteria, plus the evidence of preceding group A streptococcal infection. In the new Duckett-Jones, revised Duckett-Jones criteria, there is I had already mentioned this risk stratification. That is, there is a division of each area by a risk population, low risk population, or moderate to high risk population. This is made by two criteria. Acute rheumatic fever, if acute rheumatic fever incidence less than 2 per 1 lakh school going children between 5 to 15 years per year, or all age prevalence of rheumatic heart disease is equal or less to 1 per 1,000 population per year. This is known as low risk population of rheumatic heart disease or rheumatic fever. And the others are known as moderate to high risk population. Now comes the major criteria. In carditis, there is a change in the new revision criteria. Previously, it was only carditis. Now it is differentiate clinical carditis by hearing the murmur or the differentiate. Another term is added, subclinical carditis, which is if a patient is suspected with rheumatic fever, then echocardiography diagnosis should be done, and it is known as subclinical carditis. And both of these group is added in low risk population and high risk population. Previously, polyarthritis was the risk factor. Now it is the risk factor of low risk population. And in the moderate to high risk, now the new added criteria is monoarthritis may be a major criteria in rheumatic fever. Even polyarthralgia is a major criteria of high risk or moderate risk population. Polyarthralgia present, then it is a major criteria in moderate to high risk. Chorea, erythema marginatum, and subcutaneous nodule in both are the major criteria in the low risk zone and in the moderate to high risk population. Among the minor criteria, polyarthralgia was previously present and it is also there in the low risk zone, but monoarthralgia even is present in a moderate to high risk zone. And the fever, range of the fever, in previously it was 101, it is 101 degree Fahrenheit. Now 100.4 degree Fahrenheit is included in the moderate to high risk zone of population. ESR, commonly in rheumatic fever, there is high ESR. Previously, it was more than 60, it is the minor criteria. But here now, in moderate to high risk zone, ESR more than 30 is a minor criteria. The CRP is as before 3 milligram per DL, and the presence of a feature of myocarditis, prolonged PR interval is as before. So we can see there are some changes in the reverse Duckett-Jones criteria in low risk population, differentiating low risk population, high risk population, subclinical carditis, and monoarthritis and polyarthralgia in the major criteria, and monoarthralgia in the minor criteria, and the ESR value is reduced in the major and high risk scale. These are the change in the new 2015 Duckett-Jones criteria. So this all the features I have explained previously in the few minutes. There are two exceptions of the criteria. If the patient has chorea or the patient has indolent carditis, these Duckett-Jones criteria are the exceptions, except in these two, because this manifestation may only become apparent months after inciting streptococcal infection, so that additional manifestation may not be present and the streptococcal serology testing may be normal. So in chorea, in presence of chorea until proved otherwise, in children, if it is of rheumatic origin, and indolent carditis if other features are not even present. There it is a very important slide, and it is a common question asked in postgraduate exam. What are the evidence of preceding group A streptococcal infection? it is 11% of patient by demonstrating the rising titer of anti-streptococcal antibodies such as anti-streptolysin antibody and anti-deoxyribonuclease antibody. And if there is a positive rapid group A streptococcal carbohydrate antigen test. This is the three important feature of preceding group A streptococcal infection. There are three main changes in 2015 revised Dhaka-Jones criteria. First, the subclinical valvulitis, which is detected by echocardiography, is accepted to be a major criteria for the diagnosis of acute rheumatic fever in all patient population. Secondly, there is a recognition that the clinical utility of Dhaka-Jones criteria is determined by a pretest probability and the background disease prevalence in a population. This is done to avoid overdiagnosis in the low incidence population and underdiagnosis in high incidence, high risk group, high incidence. The third one is the in 2000 Dhaka-Jones criteria, there is a term they included possible rheumatic fever. Possible rheumatic fever are the patients where it is not possible to fulfill the Dhaka-Jones criteria because of lack of laboratory facilities or for a patient with suspected rheumatic fever. When the diagnosis is the possible rheumatic fever is made, then this patient should offer 12 months of secondary prophylaxis, and this patient should be followed by re-evaluation based on history, physical examination, and repeat echocardiography regularly. These are the investigation in a suspected case of rheumatic fever. I've already mentioned total count, ESR, C-reactive protein, throat swab culture for gastro group streptococcus infection, blood culture, streptococcal cellular. Chest X-ray may be normal, and there may be enlargement of the cardiac chiloty. This may give the clue that patients are having moderate to severe MR or aortic mitral regurgitation or acute aortic regurgitation from acute rheumatic fever, giving rise to cardiomegaly, or the patient has pericardial effusion in mild to moderate, and the patient has congestive cardiac failure. This gives the important clue of chest radiograph or chest X-ray. Echocardiography, I have already mentioned the utility of echocardiography. If there is any alternate diagnosis, depending on the clinical features of there is, if the clinical person thought that there are some separate diagnosis, then blood culture may be done, joint aspirate may be done, and anti-nuclear antibody for other autoimmune disease, serological markers, autoimmune markers may be done, peripheral blood smear for sickle cell disease. Thank you all for patience hearing.
Thank you, Dr. Dhiman, for your brilliant presentation. A lot of information we have got. Some questions already came here. Why rheumatic heart disease is more common in mitral valves? Shuna jai?
Mitral valve, rheumatic heart disease is common is mitral valve as because the mitral valve is in the low pressure area. So low pressure area, the pathogenicity is more, as because the aortic, the pressure gradient along the mitral valve is low and the pressure gradient along the aortic valve is high. So there is more pathogenicity of the mitral valve, and there is mitral valve is more here. And can I have some other comments of Wadud or Mir Jaman sir?
Can I add something? Actually, I would say we do not know. Maybe mitral valve and the whole mitral valve apparatus is rich in the substrate in which the molecular mimicry, autoimmune process, can act more. That could be the answer. But I would not say, because the pressure gradient and everything, that doesn't come into account here. Then it should be more in the right side. Tricuspid valve and the pulmonary valve are less pressure gradient area. It's not involved. We don't know. Actually, we don't know.
Actually, we do not know. And what explanation Dr. Dhiman has given, that is the explanation of infective endocarditis. Why infective endocarditis occurs in the mitral valve more than aortic valve. Then that is in the low pressure zone, infective endocarditis occurs more. And in his lecture, he has very nicely and elaborately explained everything, as because we are here for a different reason, our presence, and that is why I am telling something. Here is the, this is the subject which every examiner will touch during exam, as because I have seen 87 attendee with us. So far, I think out of 87, 80 is our fellow colleagues, those who will appear in the exam. So for them, I like to tell few questions here. These questions are almost out, as because you today we are telling and you have known the answers regarding carditis. We regularly ask, what do you mean by carditis in rheumatic fever, and what type of carditis, what is the sign symptoms of pericarditis, what is the sign symptoms of myocarditis, what is the sign symptoms of endocarditis. We very often regularly ask these questions, and we also ask these questions, what are the diagnostic criteria of rheumatic fever. Second one, what is the change occur in 2015. These are the regularly asked question. And another question we also ask, whether there is mitral valvular disease due to rheumatic fever without the history of rheumatic fever. Yes, without the history of rheumatic fever, even in 50% cases, we get valvular heart disease due to rheumatic heart disease. These are the regularly asked questions in exam, as because you are the fellow, so I have told these questions, telling that this is a question is out in front of you. Every examiner will ask this type of questions. Thank you.
Next question, how will you differentiate rheumatoid arthritic joint deformity from Charcot arthropathy?
Yeah, I have already mentioned it. In rheumatoid arthritis, there will be the change. There is only fibrous changes. There is only inflammation around the joint. And in rheumatoid arthritis, there will be joint space deformity. And there will be swan neck deformity in both the cases, and there will be and
Small joint.
In rheumatic fever, small joint in rheumatoid arthritis, small joints involvement, and it involves the large joint.
Can I say something?
Yeah.
Charcot arthritis and rheumatoid arthritis morphologically same. The deformity is same. It involves the small joints, not the large joints. The small joints, the fingers, the wrist. That's it. But the point is, two investigation. One, in post-rheumatic fever Charcot arthritis, the fibrous joint capsule are involved, not the cartilage, not the joint space. In X-ray, there is no erosion. Number two, the rheumatoid arthritis RA test. It mostly positive when there is a deformity, or there is high probability the RA test will be positive. It's negative in case of Charcot arthritis. Third is history, and probably an echo to detect any cardiac involvement is also helpful.
Okay, next one. Next, differential diagnosis of acute rheumatic fever.
Acute, I have shown this slide. The commonest differential diagnosis of acute rheumatic fever is juvenile idiopathic arthritis, which occurs in children, and the other diagnoses are reactive arthritis or septic arthritis or post-streptococcal reactive arthritis. In juvenile idiopathic arthritis, there is symmetrical large joint involvement, and the joint involvement may be in the spine also in idiopathic juvenile arthritis. And the in rheumatic arthritis, the joint involvement is migratory in nature, and it may be sometimes additive, and the joint involvement resolves within 2 to 3 weeks, and it commonly responds to non-steroidal anti-inflammatory drug, even classically to aspirin. But in case of juvenile idiopathic arthritis, it responds, but not responds totally. There is, and in juvenile, in the juvenile idiopathic arthritis, the cardiac complications are almost rare, almost absent. But in case of rheumatic, if there is arthritis for prolonged period, or in case of rheumatic fever, then there will be change, there will be carditis present. And the commonest complication in idiopathic arthritis is iridocyclitis. Eye is involved. These are the, if anything, can add by Professor Wadud or Ms. Jamal sir.
I would add a very viral thing, viral fevers. Why are we forgetting the chikungunya and the dengue fever? Viral fever are the most common cause of arthritis, arthralgia with fever in case of children. That's the most common thing. Then the other things come.
Let me add a few words actually. Actually, differential diagnosis of fever, differential diagnosis of arthritis, differential diagnosis of murmur in the heart, differential diagnosis of rash in the body, differential diagnosis of the nodules. I think I would ask the fellows, if you want to say in the exam, you can divide this so you can, you don't miss any point actually. Fever, as Professor Wadud has said, definitely viral arthritis, juvenile rheumatoid arthritis. Regarding the murmur, we must not forget about the congenital heart disease. Congenital heart disease producing murmur, it is also important. Regarding chorea, there may be some forms of chorea like in the Wills disease or maybe in related diseases. And then for the rash, another rash, though it's uncommon in our country, the Lyme's disease. The rash of Lyme's disease also mimics with the rash of Erythema Marginatum, as well as the rheumatoid nodule diagnosis will be divided in 4 or 5 points.
Okay, next another question is, AGN does not needed to lifelong prophylaxis, but why acute rheumatic fever needed?
Sir, I cannot hold the question, sir.
AGN.
AGN.
AGN does not need a lifelong prophylaxis, but why acute rheumatic fever is needed for?
In AGN, the involvement of the kidney is becomes well, and it with the antibiotics, and in rheumatic fever or in the carditis of rheumatic fever, there is a more chance of recurrence. So there is an importance of lifelong prophylaxis.
Something I like to add. No, I like to add. I think is that here is it is told that in acute rheumatic fever, almost 70 to 90% cases there is chances of carditis, and to prevent the sequelae of carditis, meaning that the chronic rheumatic heart disease, we should have to give this prophylaxis.
Can I add something? probably in post-streptococcal glomerulonephritis, the immunity that developed prevent recurrence of the recurrent infection by that particular strain. But in case of rheumatic fever, that sort of immunity never develops. Rather, whenever you get again a sore throat by group A streptococci, you again develop autoimmune process that harms your valves again and again. That's the problem. And Nazir bhai, you are unmute yourself.
Please say something about CARICOM murmurs.
About
CARICOM murmurs.
Caricon murmur. Caricon murmur, I have already explained. It occurs in acute rheumatic fever due to valvulitis, and it is present with mitral regurgitation. In mitral regurgitation, there is a pansystolic murmur if there is in the apical area, and there is a mid-diastolic murmur. In addition to this pansystolic murmur, is due to valvulitis of mitral valve, and differentiation from mitral stenosis of this mid-diastolic murmur is, in mitral stenosis, the first heart sound will be loud, but in case of acute, if CARICOM's murmur appear in acute rheumatic fever, then the first heart sound will be soft or normal, and there will be an opening snap in mitral stenosis, but opening snap is absent in case of CARICOM's murmur, and the murmur of mitral stenosis is harsh and it is rumbling, and in CARICOM's murmur it is less harsh and it is a soft murmur. And as the valvulitis improves with treatment, the murmur disappears. But if once mitral stenosis appears, the murmur is persistent. These are the differentiation from mitral stenosis, and this is about CARICOM.
Also, we do not have the pre-systolic accentuation.
Actually,
Yes.
Okay, thank you very much, Dr. Dhiman Bone, for your great presentation with question answers also. Next presenter is Dr. M.A. Majid Khan with his new live from Corona.
Thank you very much.
Majid bhai,
Dr. M.A. Majid Khan is specialist in transesophageal echo and Doppler study. And now I like to invite Dr. Majid Khan for his echocardiography presentation.
Thank you very much. Bismillahirrahmanirrahim. Respected moderator, Professor Nazir Ahmed of this session, my co-speakers, present expert panelists, and audiences. But my topic is acute findings in acute rheumatic fever. Let's start. Echo findings of acute rheumatic fever is very limited to features of carditis and the presence of rheumatic nodules. Carditis is present in 50 to 60% of cases. Dr. Dhiman already showed that it is 40 to 90% of cases. I purposefully put this figure. It is before the 2015 guidelines because it doesn't include the subclinical carditis. That's why it is shown 50 to 60% cases. Carditis is usually pericarditis and or valvulitis. It is more common in younger children. Isolated pericarditis or myocarditis is considered very rare due to acute rheumatic fever. Even it has been proved by several studies, even with myocardial biopsy, there is no involvement of the myocardium in acute rheumatic fever. That's why when acute rheumatic fever recovers, afterwards, when there is development of rheumatic, chronic rheumatic heart disease, when the heart is hugely enlarged, after corrective surgery, this hugely enlarged heart reverts to normal size with a normal systolic function, as there is no pathological involvement of the myocardium or minimal involvement. The spectrum ranges from asymptomatic to congestive heart failure. Here, the congestive heart failure is not due to myocarditis. Invariably present with some sorts of regurgitation, either mitral regurgitation or aortic regurgitation. Now, Dr. Dhiman has described vividly the different aspects of 2015 criteria. I don't want to repeat those. He is stressed about the subclinical carditis. This is the only exception. In the era of echocardiography, you know that echocardiography plays an immense role in the diagnosis of cardiovascular disease. And before this echo criteria was included, the incidence of carditis was 50 to 60%. Now it is 90%. And afterwards, I will also show in the low risk and high risk populations. Subclinical echocardiographic evidence of carditis or valvulitis are considered as part of major criteria. Echo is recommended in all suspected acute rheumatic fever cases, even without clinical carditis. That is the subclinical carditis. That is in the absence of murmur, presence of echocardiographic feature. Echo findings not consistent with acute rheumatic fever should exclude the diagnosis of acute rheumatic fever. That is the presence of murmur should find out the alternative diagnosis and at the same time excluding the acute rheumatic fever. Here is the importance of echocardiography. Now, before starting the echo findings, before describing the morphological changes, why we have started the Doppler changes. In criteria also, in all the guidelines, the Doppler criteria has been described first, then the morphological changes. Before the Doppler findings appears much earlier than the morphological changes. For mitral valve, we can see that there are 4 criteria. All 4 criteria must be met to make the diagnosis of carditis. This you can see already described by him, and that's why I have not mentioned. It is American Heart Association criteria and also suggested by World Health Organization. For mitral regurgitation, it should be seen at least 2 views. Jet length should be equal to or more than 2 centimeters in at least 1 view. Peak velocity should be more than 3 meters per second. And systolic jet in at least 1 interval. All these 4 criteria should be met for diagnosis of acute rheumatic carditis involving the mitral valve. For aortic valve, also the criteria almost same. Difference is here, the jet length should be equal to more than 1 centimeter instead of 2 centimeters in at least 1 day. Peak velocity is same. In MI it was pansystolic, in the AR it is pandiastolic. Now, as we are dealing with the regurgitation Doppler findings, we should remember what are the incidence of normal physiological regurgitations. Because while doing echocardiography, most of the echocardiographers do not know how to adjust the Nyquist limit. Because what was said, just they are finishing the echo, not handling any tools of the echo machine. So if the Nyquist limit is low, the regurgitation would be more. If the Nyquist limit is high, the regurgitation would be less. In most of the machines, it is set between 50 and 60. So we must remember the incidence of physiological regurgitation. Physiological MR, normal physiological MR, 2.4 to 45%. Physiological AR, 0 to 33%. Physiological TR, 6.3 to 95%. Physiological PR, 21.9 to 92%. For TR and PR, you can see it is fairly very high figure because of due to secondary left-sided disease with the pulmonary hypertension. And for MR and AR also figures are fairly high. That's why we have to differentiate, I will show later on, how to differentiate the pathological MR or AR from the physiological MR or AR. Just we should remember the figures. Now the morphological findings on echo rheumatic valvulitis. The acute matter of changes are annular dilatation, caudal elongation, caudal rupture resulting in flail defect producing severe mitral regurgitation. In most of the cases, anterior mitral leaflet prolapses and less commonly the posterior mitral leaflet, because in the classic MBP, posterior leaflet prolapses more. And the another finding is the beading or nodality of the leaflet tips. If such minorly, you can see this. These are transiently present and rapidly disappear after treatment. Now, there is a confusion. This slide is confusing. In Southeast Asia, as the organisms are virulent, we see that time interval between the appearance of acute rheumatic fever and the appearance of chronic rheumatic heart disease is different in the Eastern countries, that is Southeast Asia or African countries, in contrast to Western countries. In Western countries, chronic rheumatic heart disease is found in very late elderly patients, 70, 80. But in Southeast Asia, even I have seen a 9 years of boy having severe mitral stenosis. He undergone PTMC in our hospital. That's why it has been told that the changes of acute rheumatic carditis, when progresses rapidly, it turns into it produces the findings of chronic rheumatic heart disease. These findings usually not seen in the acute carditis. There is leaflet thickening, caudal thickening and fusion, restricted leaflet motion, and calcification. Now, in the aortic valve, the following findings are present both in acute and chronic carditis. This is also an exception. In mitral valve, this was not like this. Irregular or focal leaflet thickening, coaptation defect, restricted leaflet motion, leaflet prolapse, all may be present in acute or chronic carditis. Now the important point is the subclinical carditis, which Dr. Dhiman has described vividly, and the new appearance in the 2015 update. It refers to the absence of the clinical murmur or missing of the murmur by the diagnosing physician, but the presence of echodoppler findings of either MR or AR. As all of you know, this due to the evolution of the investigations in the Western countries, they are mostly clinicians, they are dependent on the investigational findings rather than the clinical findings. Still, fortunately, our cardiologists, they are much efficient than the Western countries clinically. That's why they will stress over subclinical carditis. Nearly 70% cases with polyarthralgia have equivalence of carditis. Dhiman already told that polyarthralgia in the high-risk population included in the major criteria, and in the low-risk group it is included in the minor criteria. Therefore, if arthralgia is taken as a minor criteria and echo is not done, then it leads to gross underdiagnosis of acute rheumatic. Now, what is the significance of subclinical carditis? This also described by Dr. Dhiman. Subclinical carditis, if in reality, if patients with polyarthralgia and subclinical carditis are not evaluated, diagnosis is missed and ends up with rheumatic heart disease without receiving penicillin prophylaxis. And it is a, you know very well, if there is any one patient in a family with chronic rheumatic heart disease, is a curse for the family. So, by early investigations, that is echo, we can at least try to prevent the development of chronic rheumatic heart disease. One French physician named Ernest Charles in 1884, referring to pathologists, said that rheumatic fever leaks at the joints or bites at the heart. So here you can see the importance of prophylaxis and the carditis. Now some other additional echo features of carditis. LLB may be dilated easily in most of the cases due to the presence of regurgitation. There may be thickened mitral aortic or tricuspid defects more than 3 mm. Endospheric and systolic volume easily increased due to the presence of regurgitation. But one thing must be noted, ejection fraction is not much reduced in acute rheumatic fever. As already I have mentioned that the myocarditis, isolated myocarditis is rare, and even pericarditis, the involvement of myocardium is very rare. Even if involved, the LV dysfunction is mild to moderate reduced. Acute LV, severe reduction of EF is never found in acute rheumatic. And heart failure not solely cannot be attributed to the myocarditis. In acute rheumatic fever, edematous valve more than 4 mm seen in 93.6% of cases. Increased echogenicity of subvalvular apparatus and mitral valve, best seen in parasternal lungs instead of the postambulatory. Now, previously I wanted to differentiate the physiological from the pathological mitral regurgitation. In acute rheumatic carditis, the substantial color jet in two planes extending well beyond the valve. In physiological regurgitation, there may be color both above and below the valve, not the like linear dense jets as described in the guidelines. It must be 2 cm. Color jet of MR passes over the posterior wall of belly. The physiological MR is not like this. It may go in any direction. It is a high velocity signal. There is a pathological regurgitation. It is a high velocity signal in pulse Doppler with a well-defined, dense, high velocity spectral envelope with holosystolic mitral regurgitation. Now, after observing the MR or AR on Doppler echocardiogram, still we cannot conclude these are due to rheumatic in origin. So some of the findings may help to determine the etiology of the disease. Number one is the presence of double valvulation. If both mitral and aortic valves are involved, we can say, as everybody knows, that possibly it is of rheumatic origin. Already I have told that mitral regurgitation jet is directed posteriorly. And in most cases, the anterior valve prolapses more than the posterior valve. Posterior valve prolapses more in the classic MVD. In acute carditis, there are multiple jets of mitral regurgitation, may or may not. And here is the most important thing. The presence of morphological or anatomical changes consistent with chronic rheumatic heart disease certainly proves that it is rheumatic in origin. What are the changes? Excessive leaflet motion of the tips of the anterior or posterior mitral valve leaflets, restrictive leaflet motion, including subvalvular apparatus, definite thickening of anteromitral leaflet more than 3 millimeter, and the mitral with the main valve gradient more than 4 millimeter. If these are present, we can conclude that it is definitely of rheumatic origin. Maybe there are some exceptions. Now here is the Vijay eco criteria. Though it is a bit old, published in 2008, still it helps the diagnosis of carditis in acute rheumatic fever. There are 8 criteria, each having 2 scores. It is just repetition. Mitral valve and aortic valve thickness more than 4 millimeter, 2 score. Increased echogenicity of subvalvular apparatus. Rheumatic nodules, there is bleed appearance on the leaflets. Collapse of the mitral aortic or tricuspid valve. Presence of the MR, AR or TR. Reduced mobility of the valves. Caudal tear producing severe metallic agitation. Presence of pericardial effusion. The total score is 16. And if the score is more than 6, it is diagnosis of rheumatic carditis. Now the differential diagnosis already described by Dhiman. I don't want to go into details. Only those can be differentiated by echo. I am mentioning innocent murmur, any flow murmur, that is high flow states or high fever. There may be murmur in the pulmonary area, but in the echo there is nothing. Those who are practicing echo, they find the most difficult one with the mitral valve collapse. If stress or mild MR is present, whether it is due to, especially in the children 5 to 15 years age group, whether it is due to rheumatic carditis or classic MVP. Already I have told that in the rheumatic carditis, MRZ is posteriorly placed, and in the MVP, it depends on the which leaflet prolapses, and depending on the prolapse of the leaflet, Z direction is written. And if we find that the leaflet is redundant and the thickness of the leaflet is more than 5 millimeter, it is classic MVP, no doubt. In acute carditis also, the edema thickness is more, but it doesn't crosses the plane connecting the aortomitral junction and the posterior mitral annulus. There are some congenital heart disease like Kawasaki disease. I don't want to go into details. Infective endocarditis. Infective endocarditis on some other disease or maybe superimposed valvular lesion in even acute rheumatic carditis. In infective endocarditis, depending upon the involvement of the structures, varying degrees of MR, mild, moderate, or severe. If only valves are involved, there is mild MR. If there is chordae involved, ruptured chordae, severe MR like acute rheumatic carditis. So there is a lot of differentiating points in investigations also. In hypertrophic cardiomyopathy, there are in 60% of cases there is intrinsic mitral valve anomalies. These intrinsic mitral valve anomalies can produce varying degrees of MR, and the HOCM of static variety, there is also mitral regurgitation. But it is easier by showing the hypertrophic valve, we can differentiate it. Myocarditis is frequently confused with acute rheumatic carditis. In myocarditis, valve are almost not involved. The regurgitation is either secondary, but not like acute rheumatic carditis involvement of the valve. There is no valvulitis. And as I told, in acute rheumatic fever, LV dysfunction is rare. But in myocarditis, if delayed, frequently we see the reduction in the EF, even the severe LV dysfunction. Pericarditis was present in acute rheumatic carditis and also viral or other carditis. In rheumatic carditis, 10 to 15% cases, rheumatic fever is, in rheumatic fever, 10 to 15% cases, pericarditis effusion is present, and viral pericarditis effusion may also be present. And acute rheumatic carditis, it resolves spontaneously and doesn't require any aspiration or any other treatment. Only NSAID or other treatments, it clears the effusion. Here are some images, just I want to clarify. And during an episode of acute rheumatic fever, valve changes during an episode of acute rheumatic fever, valve changes can be minor and are still able to regress. You can see the anterior and posterior mitral valve leaflets are thickened. Probably it is due to edematous thickening. If early treatment is started, it may regress, but may not regress. After recurrent episodes of acute rheumatic fever, thickening of subvalvular apparatus, caudal thickening and shortening and progression to permanent valve damage is evident. Already I have told previously. You can see the changes of chronic rheumatic heart disease. Here you can see acute rheumatic fever progressing to chronic rheumatic heart disease involving double valve, gloaming appearance of the anterior leaflet, immobile posterior leaflet, and involvement of the aortic valves. Here you can see the MRZ of acute rheumatic carditis is a dense Z, more than 2 centimeters in length and a posteriorly placed. There is a short axis of aortic valve. You can see the thickened leaflets of the aortic valve, and in the long axis you can see the regurgitant Z. There is a mild regurgitation. As already I have told that in acute rheumatic fever, initially due to inflammation, there is thickening of the subvalvular apparatus. There is a chordae. But in the resolution of the inflammation, the chordae becomes thinned out. When it is thinned out, it may rupture. And rupture producing the frail leaflets. Here you can see due to ruptured chordae, frail anteromitral leaflet. It producing the severe eccentric MR posteriorly or posterolaterally placed. But in MVP, mostly posterior leaflet involved, anterior leaflet may also be involved. While posterior leaflet is prolapses, the Z is directed anteriorly and it turns around the interatrial septum. So it is one of the differentiating points. Here is another image showing the rupture in acute carditis, ruptured chordae in acute carditis. You can see the gross non-compression, colors it is not shown. This image is shown to show the huge, large vegetation. So this non-compression gap, the image is striking the posterior wall, and due to strike, this huge vegetation develops. Here I am showing the prolapse of the posterior mitral valve leaflet in classic MVP. You can see the prolapse, it crosses the line joining the aortomitral junction and the posterior mitral annulus. In acute rheumatic carditis, it is not like this. Other AML or PML, most AML involved, and it easily doesn't cross the plane of junction connecting the aortomitral and the posterior mitral annulus. Exception is the flail leaflet. In flail leaflet, it is a to and fro, goes inside LA and LV. There is also prolapse of the posterior leaflet in the classic mitral valve prolapse. Here also you can see the prolapse of the posterior mitral leaflet. You can see the Z is central instead of the eccentric. In acute carditis, the Z is posteriorly placed. It is central. Now, almost I am coming to the end of my delivery. Before this, I am showing you the algorithm for the use of echocardiography as described by the New Zealand guidelines for rheumatic fever in 2015. Because in exam also frequently may ask if say first echo of a 15 years old male or female show either grade 1 MR, then the examiner may ask, after how many days or how many months or how many years you will do the second echo. So in very late guidelines, it is clearly mentioned. But in the Australian and New Zealand guidelines, they are mentioned. And recently, in June 2020, there is another guidelines set by the New Zealand Australian Cardiac Society. I am not showing that. I'm just showing the previous one, the 2015 one. Any person with suspected acute rheumatic fever, including cases of chorea, should have an echo shortly after admission to hospital. If the findings are normal, search for the alternative diagnosis and repeat the echo at 2 to 4 weeks. If no other finding is present, leave the patient. And if in chorea, second echo is not required. And if there is positive findings means positive Doppler and echo findings, as already I have discussed. If the Doppler echo findings are equivocal, repeat the echo at 2 to 4 weeks. At 2 to 4 weeks, if it is abnormal, there is presence of the Doppler and morphologic findings, then the second echo should be done at 4 to 6 weeks. If the science progresses, medication commences, and if recommended by the cardiologist. In our country, as the charge of echo and Doppler is not so high in comparison to Western countries, we can follow these guidelines to prevent the development of chronic rheumatic heart disease and saving many patients both financially and by life. Of course, I want opinion from my expert panelists. I want to see later on about this. So finally, just recapitulation of the recommendations. In my second slide, I have shown the recommendations. Echo with Doppler should be performed in all cases of confirmed and suspected acute rheumatic fever. It is class 1 indication, level of evidence B. Echo should be done with diagnosed or suspected acute rheumatic fever, even if documented carditis is not present on diagnosis. It is class 2A, level of evidence C. Echo should be done to assess whether carditis is present in the absence of auscultatory findings. That is to find out the subclinical carditis. There is class 1 indication, level of evidence B. And echo Doppler findings not consistent with carditis should exclude the diagnosis in patients with a heart murmur. That is, if heart murmur is present, but echo findings not support the diagnosis of rheumatic carditis, we can diagnose some of the diseases, say congenital heart disease. That's why it is a class 1 indication and level of evidence is B. So, thank you very much for your patient hearing. I don't know whether I could satisfy you or not, satisfy the students or not. Thank you very much.
Okay, thank you very much, Dr. M.A. Majid Khan, for your brilliant speech. Just one question arrived already. How will you differentiate rheumatic carditis from chronic rheumatic heart disease echocardiographically?
Okay, it's a very important question and very difficult also and confusing also, because for the clear cut over on, we take either 3 or 4 minutes, but for giving decision like this, we take even 30 minutes also, because upon our decision, the clinician or take his decision to start the prophylaxis. There are some important ones which I am mentioning first. First, in carditis, there is no subvalvular thickening. In chronic rheumatic heart disease, there is subvalvular thickening due to caudal thickening and fusion, and the restricted leaflet motion. There is the rigidity of the valve. We find usually PML immobile and doming of the ML in chronic rheumatic heart disease. In acute carditis, no such findings. In acute rheumatic fever, there is prolapse of the either anterior or posterior mitral leaflet, but in chronic rheumatic heart disease, prolapse is rare. Even if mitral regurgitation is present, there are several terms like overriding regurgitation, coaptation failure, not clear-cut prolapse. But in carditis, it is prolapse. And in carditis, due to involvement of the subvalvular apparatus, already I have mentioned, if there is a ruptured cardi, it may produce flail mitral valve leaflets. It is almost absent in chronic rheumatic heart disease. And the presence of pericardial effusion, because pericardial effusion, it is 10 to 15% cases already have shown present in rheumatic carditis. It is almost absent in chronic rheumatic heart disease, except in the cases of severe left-sided disease with severe pulmonary hypertension that may cause the pericardial effusion. The presence of the rheumatic nodules, if present, it denotes rheumatic carditis. It is absent in chronic rheumatic heart disease because it rapidly disappears after treatment. And the most important, I should mention it first, the calcification. Calcification never present in carditis. It is always present in chronic rheumatic heart disease. This is the most important differentiating point. And the LV dysfunction. LV dysfunction never present in chronic rheumatic heart disease if arrhythmia is absent. In acute carditis, I have mentioned that the myocardial involvement is rare, but may be present and may produce mild to moderate LV dysfunction, not severe LV dysfunction. So, if we find the LV dysfunction, it goes in favor of carditis. There are less important point also. Involvement of the annulus may produce annular dilatation, which will be primary annular dilatation or secondary due to regurgitation. Secondary dilatation may also be present in chronic rheumatic heart disease. The primary involvement of the valve and producing the annular dilation always present in acute rheumatic carditis. So there are so many unimportant points. I think by these points we can conclude that it is whether acute rheumatic carditis or chronic rheumatic heart disease. And one important point, before starting any echo, we always see the age of the patient. If say one patient comes with 60 years, we don't at all think about the carditis. So in the age group 5 to 15 years, we are differentiating between the carditis and the chronic rheumatic heart disease. So age is very important. That is not echo finding, but age must be important. So if any point left, our expert panelists, they will elaborate, I think.
Any comment from expert panels, please? Any comments?
Regarding, I like to say, regarding echocardiography, this is our regular practice. Those who do echo, that before starting echo, placing the echo probe over the chest, you will auscultate the patient and you will not miss the.
নাজিফ, আমি একটা ক্লিয়ার করতে পারি?
Yeah, of course.
আমি আসলে মাঝখানে কথা উচিত ছিল। আসলে ওই যে আগের যে কোশ্চেনটা ছিল সেটা আসলে একটুখানি করা উচিত ছিল যে ক্রনিক রিউমেটিক হার্ট ডিজিজের পেশেন্ট তার যদি রিকারেন্স হয় তাহলে আমি আইডেন্টিফাই করবো কি করে, কারণ অ্যাকিউট রিউমেটিক ফিভার এবং ক্রনিক রিউমেটিক হার্ট ডিজিজ মাজিদ ভাই বিউটিফুলি কিন্তু সবগুলো পয়েন্ট আলাদা করে বলছেন এবং ওটা অবভিয়াসলি calcium thickening, subvalvular changes, prolapse of the valves, all these are clear cut je bola jabe. And acute recurrence jeta holo chronic rheumatic heart disease mধ্যে সুপারভেন, এটা কি জ্বর অন্য কারণে হলো নাকি রিকারেন্স হলো সেটা বোঝার জন্য ইকোর রোল কি সেটা হয়তো আমাদের জন্য ইম্পর্টেন্ট হতে পারে। এখানে পেরিকার্ডিয়াল ইনফেকশন একটা খুব ইম্পর্টেন্ট ফ্যাক্টর। দ্বিতীয়টা হলো তখন কিন্তু আমার অন্য ফ্যাক্টরগুলো নিতে হবে, আমাকে এসও টাইটার দেখা উচিত, আমার সিআরপি দেখা উচিত এবং ব্লাড কালচার করে দেখা উচিত এটা ইনফেক্টিভ এন্ডোকার্ডাইটিস না, সিবিসি দেখা উচিত ওটার প্যাটার্নটা কেমন, আমাকে ওইগুলো বিবেচনায় নেওয়া উচিত। ওই জায়গাটা কিন্তু ডিফিকাল্ট যে এটা রিকারেন্স হয়েছে নাকি এটা আসলে ভাইরাল ফিভার, অন্য একটা জাস্ট সিম্পল একটা ভাইরাল ফিভার ইন প্রেসেন্স অফ ক্রনিক রিউমেটিক হার্ট ডিজিজ। মাজিদ ভাই কিছু বলবেন এই ব্যাপারে?
Here is not echocardiography. Dr. Dhiman told that if clinically any presence of change of or presence of a new member in a known case of chronic rheumatic heart disease, it may denote the recurrence of the carditis. But in USA, in one study, they found it very difficult, and they say the rheumatic nodule, it helps in the diagnosis of recurrent carditis. Even they injected some blood or even plasma into the subcutaneously, arteriogenically to produce the nodules. If the nodules appears, so it is diagnostic of recurrent carditis. It is not echo finding, but last night I read this in one study.
যে রিকারেন্স আইডেন্টিফাই করা খুব কঠিন আসলে অনেক সময়।
Okay, next presenter, Dr. Khalid Mohsin, Associate Professor and Senior Consultant. He is very popular among the fellows and all doctors. He will discuss about management and prophylaxis of rheumatic fever. Dr. Khalid Mohsin.
Thank you, Professor Nazir Ahmad, for your kind introduction. Learned moderators, panelists, and dear audience, I am starting my presentation. First of all, I would like to seek your apology for not being able to use the template of National Heart Foundation Research Institute because for a computer problem. So I am presenting without this template. Actually, the 4-person presentation is like a relay race actually. The baton is passed from one participant to another, and as the final participant, I am in a hurry to cross the finishing line. So please bear with me. So prevention and treatment of acute rheumatic fever. Actually, why we need to treat the acute rheumatic fever? Number one goal is to eliminate the streptococcal infection from the body by appropriate antibiotics. If we eliminate the antigen in time, the post-infective sequelae can be shortened or maybe less severe. Then second objective is to treat the clinical manifestation of the disease. The 3 of them are very important. Arthritis is the commonest, carditis is the most dreadful, and chorea is also very, I think, makes the parents very anxious. And the final objective is to prevent the recurrence of the disease. As Dr. Najmul Laila has said that the acute rheumatic fever and rheumatic heart disease is more prevalent in the lower socioeconomic conditions, though the access to healthcare in this group of patients is quite limited. But they seek help from some non-registered physician, and when the patient come to us, they are usually partially treated. So how we can eliminate the streptococcal infection from the throat? The phenoxymethyl penicillin is the commonest drug. In the patients of more than 30 kg, the dose is 500 milligram twice or 3 times a day for 10 days. And those who are under 30 kg, we can give them 250 milligram 2 or 3 times a day for 10 days. Initially, in many guidelines, it was mentioned that this drug should be given 4 times a day. But I think it is very difficult to administer a 6-hourly dose. So it has the duration of the interval of the dose has been increased, and the most common treatment is the injection of benzathine penicillin. It is being given intramuscularly for the patients who have more than 30 kg. The dose is 1.2 mega units, and those with less than 6 years of age and less than 30 kg, the dose is 600,000 interstitial unit. This is a single dose. Amoxicillin is a very commonly available antibiotic. It can also be used, but it is not recommended in many guidelines. The dose is 50 milligram per kg in 2 or 3 divided dose for 10 days. And it is important to treat the streptococcal sore early, because studies have shown that if it is treated within 9 days of the onset of sore throat, the subsequent features of the complications or the duration of illness can be shortened. So it is very important to diagnose the disease early in the course of illness. And there are few options for the penicillin hypersensitive patients. The cephalosporin can be given for 10 days, but we should keep in mind that some patients may have cross-reactivity for cephalosporin as well. Clindamycin is another drug. It can be given 3 times a day. Clarithromycin, it is also an option, but we should be aware that it is a very bitter drug of very bitter taste, and in case of children, it is very difficult to use. Azithromycin has an advantage. It can be given once a day, and the duration is 5 days, and the maximum dose is 500 milligrams per day. Ibuprofen, the arthritis is the commonest, and it is all seen in almost all patients of acute rheumatic fever. Traditionally, aspirin has been used for treating arthritis, but the dose of aspirin is quite high. The starting dose is about 100 milligram per kg per day. It has been given for 2 to 3 weeks, and after the attenuation of symptoms and the inflammatory parameters, the dose is reduced to 60 to 70 milligram per kg per day, and aspirin is given in 3 divided dose. And as Professor Wadud has said, the viral illness, they mimic acute rheumatic fever. We have to exercise extreme caution in using aspirin in viral illness, because it may produce a life-threatening illness known as the Ray's syndrome due to mitochondrial damage with almost 30% mortality. So if we suspect viral illness, we should refrain from using aspirin. And the other commonly used NSAIDs are ibuprofen, ketoprofen, and naproxen. These all are given in twice daily use. And the advantage of naproxen is it is available in the market with a fixed dose combination with esomeprazole. So this is an advantage. And as the arthritis of rheumatic fever usually affects the weight-bearing joints, so bed rest is almost implied the patients are usually unable to work when it affects the ankle or the knee joints. So the bed rest should be given until the joint tenderness and swelling is reduced sufficiently and the inflammatory markers are attenuated. But we should be cautious to prevent the muscle wasting, particularly the quadriceps muscle. If it is cannot be prevented, it will lead to difficulty in walking even after the arthritis is. Rheumatic fever is a non-deforming arthritis. We should keep in mind. There is a variant of arthritis, as Dr. Dhiman has said, the post-streptococcal reactive arthritis. There is some difference. It occurs a bit early in course of the illness, and it is not very much responsive to commonly used NSAIDs. And it has a tendency to affect the joints of the axial skeleton of the body. And in this group of patients, steroids and other disease-modifying agents like methotrexate, sulfasalazine, etc. can be used. Physiotherapy is also an option, additive option. And these patients should be offered a long-term secondary prophylaxis for recurrence of rheumatic fever, as some of them can develop a late-onset carditis. Carditis, as I have already mentioned, it is the most dreadful complication. The drug of choice is prednisolone. The dose is 1 to 2 milligram per kg per day. Maximum dose is 80 milligram per day. And it is usually used in full dose for 2 weeks, and then it is started to taper over 2 to 4 days, but not to taper is a very large dose. It is the recommended tapering is 2.5 to 5 milligram every 3 days, so that the relapse is prevented. And to prevent relapse, after 2 weeks, aspirin is started at a dose of 50 to 75 milligram per kg per day in 3 divided doses. And aspirin and steroid should be overlapped for 2 weeks, and for the rest of the period of illness, aspirin is continued as a monotherapy for 4 to 12 weeks. And one thing we should keep in mind, in young children, prednisolone can cause retardation of growth. So it is better to give prednisolone is in maximum 2 divided dose. The 2/3 of the dose is given in the morning and 1/3 in the evening. But it's quite a big dose, so single dose use is practically not feasible. And how we judge the response to treatment? We check for sleeping tachycardia, inflammatory markers, PR interval on ECG. And as we know, the patient of carditis can develop heart failure and some arrhythmia, and they should be put on fluid and salt restriction, and other drugs like beta blockers, vasodilators. Vasodilators commonly used are captopril or ramipril in low dose. Diuretics like furosemide with or without spironolactone. And there is a atrial fibrillation. And arrhythmia, though rare, if develops, can be managed by antiarrhythmic medications. Sydenham's chorea, it is Dr. Dhiman has already described Sydenham's chorea. It is caused by a lesion in the caudate nucleus, and it is very much terrorizing for the parents. And it is sometimes misdiagnosed as a neurological or psychiatric illness, and maybe confused with hysterical conversion reaction in the girls. So in the mild form of disease, oral diazepam or phenobarbital can be given. But if the parenteral drug is required, haloperidol is the drug of choice. But we must keep in mind to combine it with procyclidine to prevent the extrapyramidal symptom or extrapyramidal syndrome. And nowadays, the preferred drug is sodium valproate at a dose of 15 milligram per kg per day. and it should be administered for 12 weeks or 2 to 4 weeks after stabilization of the clinical symptoms. Sodium valproate has another additional advantage of mood stabilization, and we should keep in mind to monitor the liver function and the hematological parameters when we are using sodium valproate for a long time, because these parameters may be altered by sodium valproate. Now comes the bed rest. It is a very integral part of the management of acute rheumatic fever. If a patient has only rheumatic fever without carditis, the bed rest will be 2 weeks and the gradual ambulation in 2 weeks on if the patient on NSAID. If there is carditis without cardiomegaly, the bed rest should be for 4 weeks and ambulation in 4 weeks. The carditis with cardiomegaly without heart failure, the bed rest will be for 6 weeks, gradual ambulation in another 6 weeks. And if there is heart failure, the bed rest should be continued until the heart failure is controlled and very slow ambulation. And if the patient is a school-going child, the patient should not go to school for that academic year. The secondary prevention of rheumatic fever is very important, and it is very much cost effective and very much advocated by different guidelines, because the patients with first attack of rheumatic fever are prone to recurrent attacks. Benzathine penicillin is the drug of choice. It is given in our setting, it is given in 3 weekly intervals, and in many countries it is given 4 weekly. But there are some studies which compared the 3 weekly and 4 weekly dosage, and it has found out that in a highly endemic area, the 3 weekly dose is recommended, and it is more effective in preventing the recurrent attacks of acute rheumatic fever. The dose in individuals of more than 30 kg, 1.2 mega units, and those with less than 30 kg weight, the 600 mega units. And alternatively, the oral phenoxymethyl potassium can be given, but the patient compliance should be just before prescribing oral potassium, oral phenoxymethyl penicillin actually, because the patient can drop the dose and they come back with recurrence. And regarding the intramuscular injection, it should be given by a trained person, because there are some local complications can occur, and there are some reported cases of anaphylaxis. So before the first dose, some diluted drugs can be dropped, given by a drop in the conjunctiva if to look for any allergic reaction. And the intramuscular injection should be given in the upper outer quadrant of the gluteal region. And if there are some reported incidents of abscess formation or sciatic nerve malfunction or injury if the injection is not given properly. And in penicillin hypersensitive patients, erythromycin can be given twice a day, azithromycin 250 milligram daily. Sulfadiazine can also be in prescribing erythromycin. There are some incidents of sudden death in young adults because of the QT prolongation and torsades de pointes ventricular tachycardia, particularly if some patients have congenital prolongation of QT interval. So we have to be cautious in about using erythromycin. And how long we should use the prophylaxis for secondary prevention? If there is no cardiac involvement, it should be continued for 5 years or to the age of 21 years, whichever is longer. If there is carditis, but it's a completely resolved cardiac lesion, the duration should be continued for 10 years to the from the last episode or the age of 21 years, whichever is longer. And the patients with residual valvular damage, the episode, the the prophylaxis should continue up to the age of 40 years from the last episode. And in the patients of documented relapse, high risk of infection or valve replacement, the prophylaxis must continue indefinitely. A bit of doubt should be in favor of treatment, not in favor of stopping. The secondary prevention I have already mentioned. Now we can recapitulate a few things about the prevention strategy. Number one is the primordial prevention. This is the beyond the scope of the treating physician. This is mainly the socioeconomic improvement, the improvement of housing or dormitory infrastructure, avoidance of overcrowding, personal hygiene improvement, nutritional status improvement, access to quality health care improvement, and creating awareness about the disease in the media. Primary prevention, I have already mentioned, this is the prevention of the first attack by treating sore throat. But the problem is for preventing one rheumatic heart disease, thousands of sore throats needs to be treated. And therefore, the cost effectivity is questionable, because the sore throat, only 30% of the sore throat is caused by streptococcus. Rest of the 70% is caused by the viral infection. And we can inspect the sore throat. The bacterial sore throat is usually the tonsillar area is the exudate is seen, but whenever the doubt, a bit of doubt should be in favor of treatment as a bacterial sore throat, not as a viral sore throat. And these are the patients who should be, the secondary prevention is more important from a clinical point of view, and it is feasible to patients who should more attention. This is the younger patients. The time elapsed after initial attack. The initial attack tend to occur within a short interval of the first and crowded dwellings. The persons with a positive family history of Ella, as elaborated very nicely in her deliberation, that there is some genetic clustering of HLA antigens. So the genetically predisposed individuals should be treated more aggressively. And some high-risk professionals like teachers, healthcare workers like doctors and nurses who come in close contact with children aged 5 to 15 years should be treated with an aggressive intent. The tertiary prevention, it is mainly it is a damage control measure. It comprises medical treatment, interventional procedures like the PTMC and the mitral clip procedures, the surgery like the valve repair and valve replacement. These are more in our domain. This is a transition of streptococcal sore throat to rheumatic heart disease, the pharyngeal streptococcus, and among those caused by group A streptococcus, 3.3 to 3% lead to acute rheumatic fever, and those who develop acute rheumatic fever, about 40 to 60% develop carditis, and those who develop carditis, 40 to 60% develop chronic rheumatic heart disease. So, if we block here by antibiotic, this is the primary prophylaxis, and after that, this is secondary prophylaxis. And the last topic is a vaccine. Though rheumatic heart disease or acute rheumatic fever is not a direct infectious disease because it's a post-infective sequelae. So, vaccine has to be directed against development of sore throat by group A streptococcal infection. And many vaccines have been tried, but the results have so far not been very encouraging. These are the two vaccines which has completed phase 1 and they are in phase 2 trial. The MJ8 vax, it is developed, it is a 29 amino acid peptide analogous to the M protein of group A streptococcus. It is being tested in Queensland, Australia. And we all know the Aboriginal population of Australia and New Zealand are very highly susceptible to rheumatic fever and rheumatic heart disease. They have a lot of interest and a lot of funding. And another vaccine is being tested, the 30-valent strep tenova vaccine. It is being in trial in USA and Canada. This is one of my favorite pictures of a very serene environment in Jaflong, Sylhet. I think it's the favorite picture of Professor Abdul Wadud Chaudhuri and Fazila Madam as well. But the environment presently is not like this. The environmental degradation will disappoint many of us. But if we cannot control the environment, there will be a resurgence of rheumatic fever and rheumatic fever will make a comeback. So we have to be very careful about it. Thank you very much for your patient hearing. Thank you, Nazir bhai. And
thank you for your
moderator and the learned panelist. If you have any questions, I will be happy to answer. And if I am unable, the panelist will take over.
Very few questions from the audience. Number one, does secondary prophylaxis need after MBR?
Yes, definitely. Because there are other 3 valves left in the heart. These are all native valves. Particularly the aortic valve is a very vulnerable valve after the mitral valve. So we need to protect those. Even the double valve replacement, after double valve replacement, we need to protect the tricuspid valve as well. You all know the tricuspid valve can be also affected by the rheumatic fever process as well.
Another question, whether Bangladesh is a very low risk or the high risk area according to the 2015 updates.
Actually, Bangladesh, the latest the geographical map has put Bangladesh in a low risk area. But still, there is a lot of vulnerable population. Particularly, I will mention about the persons working in the garment industry. There are younger people working in an overcrowded environment, living in an overcrowded environment, and they are very vulnerable for acute rheumatic fever. I think, though by statistics, Bangladesh is in a low risk area, but the prophylaxis should be given in a dose recommended for high risk areas.
Okay, thank you. Any comments?
Thank you all the speakers for excellent speech. For practical purpose like fellows to continue full lectures running 2.5 hours, I think it is very much difficult to understand, very much difficult to engulf. But lectures are excellent and we have enjoyed much. Thank you all the speakers and all the participants, and thank you authorities, Professor Fazila Malik and other authorities, my teacher, Professor Brigadier Malik, from the National Heart Foundation for inviting me in this classroom or in this program. Thank you all.
Thank you. Any comment from the experts?
Can I ask a question?
Yes.
Okay.
Khalid bhai,
Yes.
One axiom was that previously taught, if you have a demonstrable valvular chronic rheumatic heart valvular lesion, take the prophylaxis lifelong. But you have modified it to some extent. But is it pertainable to low prevalence area or to high endemic area? That's my question.
Actually, it has been shown that the recurrence of rheumatic fever, recurrent attacks are more dangerous for developing the valvular problems. Recurrence is, as the age progresses, the recurrence becomes less and less. And it is almost beyond 21 years, recurrence is definitely is almost negligible. But what I think is the guidelines say that it can be stopped after 40 years. But in our country, penicillin is very available, is a very cheap rate, and you don't even need a prescription to buy a penicillin. Most of it available over the counter. It's my personal opinion that it is better to continue lifelong in a patient with documented valvular damage, because if we need to repair a valve or replace a valve, it is from an economic point of view, it's a very much burden for majority of our patients. So if we can prevent those sequelae by regular penicillin prophylaxis, I think it is better to continue it beyond the age of 40 years.
One point, can I tell something?
Yeah.
Yes, please.
Frequently we see that patients coming with a valve replacement outside the country, returning to our lab for follow-up. Frequently we see the prescription with discharge treatment. There is no penicillin prophylaxis in most of the patients. If there is either pure MVR or pure AVR, if the concomitant along with MVR, trace AR or mild AR, along with AVR or trace MR, there is difference. And why this disparity between our neighbor and our country? I don't understand it. In my view, it should be continued. But why this disparity? I should have any comment.
There was a national guideline under the leadership of our mentor, National Professor Brigadier M.A. Malik. In late 90s, we had a national guideline, but unfortunately, this guideline has not been revised afterwards. And this, in that guideline, it was advocated that the patient with documented valvular damage should have prophylaxis for lifelong. I think it's a time to revise that our own national guideline, because we can, in that way, we can give a practical advice to the patient.
Any comments?
As Mijal Bhai was saying, well, as a class, these sessions are very long, but these are available in YouTube, I think, so, or Facebook. So the students can actually review through the course at their own time, at their own pace later on. They can always go through them again and again and learn a particular point as per their wish. So this formative way of describing a disease or a process in whole, in partly by different specialists, all of whom can give their wholehearted effort in describing in total the present available evidences and knowledge, is really very good. I would suggest that you should continue it as it is. And another thing is that I will share one experience. One of my patients, hypertensive diabetic, near a lady, She developed acute rheumatic fever. She had rheumatic heart disease. She developed acute rheumatic fever, but it was diagnosed late because she was 40 or 40 plus, something like that. And she developed arrhythmia and she died. From that experience, my thought process is that we should never discontinue prophylaxis if there is established valvular heart disease. Thank you, everybody.
Okay, thank you. I like to thanks Institute of Pharmaceuticals তাদের সামগ্রিক সাহায্যের জন্য এবং আন্তরিক ধন্যবাদ। তারা ফিজিক্যালি টেকনিক্যালি তারা সাপোর্ট দিয়েছেন নাম, এবং আজকে যারা প্রায় 110 জনের মতো 107-8 জন আমাদের মানে উপস্থিত ছিলেন যারা, তাদেরকে সবাইকে ধন্যবাদ। এই ধন্যবাদের ব্যাপারে প্রথম দুটি কথা হলো, আমি আমার জীবনে দুটা যুদ্ধ দেখলাম। একটা যুদ্ধ 2019 সালের করোনা যুদ্ধ, যেটা এখনো চলছে, যেটাতে আমরা অদেখা শত্রুর সাথে। আর একটা যুদ্ধ আমি দেখেছি 1971-এ মুক্তিযুদ্ধ, যেটা আমরা চেনা শত্রু। আজকে এই বিষয় নিয়ে কথা বলার নাই। আমরা যারা করোনায় অনেকেই আক্রান্ত, অনেকেই হয়তো ভবিষ্যতে কি হবে জানি না। তবে আমি সেই ছোটবেলার 2000 আর কি বলে 1971 সালের যুদ্ধের সময় আমরা রেডিওতে শুনতাম, বিবিসিতে, যেখানে অনলি মিডিয়া, যেখানে সত্যি কথাগুলো শোনা যেত। এই অনুষ্ঠানের অত কিছু আমার মনে নেই, কতগুলা কথা শেষের দিকের মনে আছে। সেটা সেই বিবিসির ভাষাই আমি আবার বলতে চাই, আপনারা যেখানেই থাকুন, যত দূরেই থাকুন, ভালো থাকুন, সুস্থ থাকুন, নিরাপদে থাকুন, এই কামনা করে আজকে আমরা শেষ করে দিচ্ছি। সবাইকে ধন্যবাদ, ইনসেপ্টটাকে ধন্যবাদ, সবাইকে ধন্যবাদ। থ্যাংক ইউ ভেরি মাচ এভরিওয়ান। থ্যাংক ইউ।